One of the things that CLL patients should keep in mind is because of the advent of a lot of these novel therapies, patients who had more adverse genomic features, high-risk disease, 17p, p53 deletions, certain molecular mutations that are high risk, we're obtaining data on a lot of these mutations and how they benefit from these novel therapies. The good news is with chemoimmunotherapy, patients' responses to traditional therapy with high-risk features tended to be more short and limited duration. Now with novel therapies, these high-risk individuals are becoming much better risk patients in a way because these therapies do much better for those individuals. So that's the good news, is novel therapies, absolutely. So testing is really important. I think patients with CLL absolutely need to be educated that they need their doctor to test them for their genomic features, because that will help, particularly if a discussion comes up when they do need therapy and when they require therapy. If one is proposing still more traditional chemoimmunotherapy or a monoclonal antibody therapy like obinutuzumab, do they have any high-risk features that we might steer them away from that type of therapy? Because we would. I think that patients need to know that high-risk features we tend to use a novel agent for those individuals, whether it's a novel agent in combination with something else or a novel agent by itself. But the good news is that the newer therapies really have prolonged the progression-free survival and overall survival of patients with high-risk features. So testing is important. We're getting to a finer level where hopefully, I think FISH for cytogenetics and for chromosomal abnormalities is pretty standard. But hopefully we'll also get to a point about looking at molecular features such as Notch and BRC and other associated mutations that also might be high risk, and what does that mean and what therapies might be better for those individuals too. Those are much smaller numbers, much more immature data, but we're refining, and by doing these types of clinical trials with novel agents, combinations, single agents, we're really trying to learn much more about the biology and what therapies might be tailored to each individual. Because as I said, I'm very conservative. I'm not entirely convinced that everybody needs triple therapy or doublet therapy. It really depends. And I think we need to have that head-to-head data and long-term follow-up. But I think testing, we're getting better and more sophisticated, and hopefully we'll be able to tailor therapies better for different subgroups and really get to know, maybe if you're good risk, you only need this, and if you're poor risk, this would be great. So that's where we're getting to 11. We need years of maturity, but it's a very exciting time.